So we now move very quickly on where we could actually use CBCTs. Again, it's very proven that MPR views are very important in assessing pathologic lesions. We could actually see not just extent or the depth of the lesion, we could even measure it, but we could also see some of the changes in the osseous architecture. Like in this particular case, we already see what is consistent with most cysts, that it would resorb bone, and as much as you could see here, it has almost completely obliterated the facial or buccal aspect of this maxilla and has not completely obliterated or the palatal side, but has very thinned it out. Cyalolith, since it's very calcified, could be clearly seen on your CBCT, would show here, like in one of these cases of a very small cyalolith um, on your submandibular gland duct opening, and you would see it as this amorphous calcifications. Now, since most of our lesions are found intraosseously, thank God, CBCT being of high value in terms of assessing osseous structures has become a very important tool in terms of diagnosing and planning intraosseous lesions or most of our pathologies. A paper here published showing value of CBCT in terms of endodontics, wherein because you still have intact buccal and lingual cortices, you cannot see this small starting radiolucency on the mid-buccal region because of a lateral canal. In this particular case, the only thing that warranted CBCT imaging is that the patient appears to have symptomatic findings even after a rather good root canal. So again, in this case, the periapical radiograph did not show anything because you have very clear, thick, intact cortices. On CT scan, it has been confirmed as the study or case report has cited the enlarging, acutely enlarging mass or infection that is growing through the lateral canal on the mid um, in between or interradicularly between the roots of these molars. So that's where it is very good. Again, I cut or screenshot view of the advantage of using CBCTs in terms of assessing pathologies, like in case of impacted teeth. You now could assess in the comfort of your own home on your computer where the impacted tooth is, how is it projected, where is it in relation to your um, go back here, in relation to the mandibular canal. Is it on the buccal, lingual? Is it really approximating how close it is to your canal? So that's what you could see. Even for the maxilla, you could also see differences. You now know why on periapical radiograph you see your palatal apex seem to be superimposing or is almost seen to look or appear inside the sinus. Well, that's obvious because when you look at the periapical radiograph, you would see the apex overlapping the image because the floor is far more inferiorly than the apex of your maxillary palatal roots. So that's where one of the advantage of three-dimensional images is. Here's another patient wherein, based on 3D imaging, we are able to assess the sequestrum that happened, in this case, helpfully suggesting a possibility of osteonecrosis of the jaw because of anti-osteoclastic medications. Now, I oftentimes show this particular picture in pathology classes. This is a 3D view of um, a patient with a gingival cyst, another similar odontogenic cyst that was that came presenting manifestations. Patient came with a radiograph, manifestations of a possible oroantral communication, given the history of prior extraction and later on having discharge coming out of the site, a non-healing extraction site, pointing to possibility of oral communication. But upon interview, clinical examination, signs of sinus problems were off, and that gave me um, the drive to investigate further whether or not this is really a oral communication. So I asked patient to take a CBCT of that particular slide, and well, needless to say, it confirmed my suspicion that it was not an oral communication, although the panoramic radiograph highly suggests that it is a possible um, oral communication. Clinical examinations and history, however, point to signs and symptoms against that. And CT scan just simply confirmed my suspicion that it wasn't an oral communication, but rather a cyst that was secondarily infected, thus the discharge. And it shows that the sinus is still intact, although displaced. So that is where CBCTs, three-dimensional images, are very important. Now, borrowing one of this image from a diagnostic um, center that I know of, a panoramic radiograph that doesn't seem to show anything, but on uncut um, slices, you could clearly see a defined decrease in lucency with areas of opacity, showing signs of uh, bone expansion or periosseal reaction. This is not apparent on your panoramic radiograph because since it is not as big, the density behind it masks this particular image. Okay, so that's where CT scan or three-dimensional imaging, in this case CBCT, is very valuable. Okay. So in assessing pathologies, like in this case, we could move further in not just assessing or seeing what is inside, how um, the structures are reacting, but we could even take it further and get a stereolithographic image from the CT scan view in order for us to further plan ahead. Now, STL views are very important nowadays in navigation surgeries, in um, guided surgeries, but that's again a different story, and it just comes from what three-dimensional images has already given us. Another view of another case of a young child with an expansile mass that shows density that is almost similar to that of tooth structure and therefore is highly suggestive of a calcifications. This goes to clinical application. From diagnosing as part of the application three-dimensional images, we could now use that information we got from diagnosing and use the same three-dimensional image to plan our cases in three dimensions. Like I've shown you this earlier, I've used this very early on, CT images that help me identify the extent of my tumor margins, and thus I was able to plan very well its resection up to where I could actually resect. Later on, I used CBCT, three-dimensional image, to assess the success of my graft and even the ability to place implant as part of the reconstruction. So planning was a lot easier now with three-dimensional images. Impacted teeth could now be assessed more than ever, as what this series of cross-sectional cuts would show. It now gives us ability to determine how close it is from one side or the other. So in this particular case, it doesn't just simply tell me and confirms that this particular impacted tooth is inverted, the crown is located more superficially or coronally than caudally in comparison to its apex. The apex is more caudal than your crown. What this also tells us is that the crown of this impacted tooth, although very high, is closer to the buccal cortex rather than the palate. So if I'd like to remove this, except if I want to pull it out, which is uh, rather hard through the apex, then I'd rather open up through the buccal cortex rather than access it to the palate because this is thicker compared to this one. So in terms of planning of what you could do, three-dimensional images really has advanced the way we see our cases and therefore has made a lot of our work a little bit more predictable in a sense. Another particular case of an impacted tooth with a supernumerary um, dentition, preventing it from coming out. Signs of possible um, cystic formations also evident. Multiple impacted supernumerary tooth could be very well assessed with three-dimensional images as it tells us where this teeth um, is located or found. So definitely it will be very hard for anyone to determine how to remove all of this without the help of three-dimensional imaging. Okay. Another particular example that I have was that of a patient wherein two-dimensional image seems to have a, um, according to those that referred, an odontoma on the apices. Now, um, not going into diagnosing pathology, but looking at since two-dimensional image showed an amorphous looking solid object as dense, radio dense as that of tooth, one may think that it might be a complex odontoma. But as this CT scan or three-dimensional cut shows, it is, it appears amorphous because it overlaps the image. What it actually is a supernumerary tooth that has a gemination, two crowns over one root impacted, and that's why in two-dimensional images it appears amorphous. But in three-dimensional view, you could clearly discern the shape of one crown to another. Now, this goes beyond diagnosis. This goes to planning. Definitely, this will be more difficult in terms of removing, particularly that one crown is located on the lingual of a tooth, but because the tooth or the supernumerary impacted tooth has two crowns. So this is where, again, three-dimensional image are very, very important. So I've shown a lot of applications in terms of maxillofacial surgery, but CBCT has gone beyond just simply maxillofacial surgery. Orthodontics has used it not just to determine clearly landmarks, but in terms of planning, like one case that I had before of several impacted teeth, the ortho, together with me as we planned it, determined in CT scan which tooth could actually be forcibly erupted at the same time, like playing pickup sticks. So together with the orthodontist, we planned on moving one tooth out. He asked me to expose another so that he could move it. It worked well. We eventually didn't have to remove, or I eventually didn't have to remove any of these impacted teeth. Everything came out. But that was only possible because we could clearly see in three dimension where each tooth and root is, even the morphology of the root. Here we cannot determine whether one has a dilaceration or not. Fortunately, in this case, everything was straight. So it's just a matter of moving or knowing which tooth he would move first and which would be done next and so on. Of course, this is an overkill for Resto, but imagine we could actually see um, caries lesions, even very small ones, in this case, determine even how close it is to the pulp. Periodontal diseases could be very well assessed even cracked tooth in terms of endodontics, and determining whether or not something is still restorable would be more appreciated in CT scans. Because now we could not just identify that there's a vertical fracture, we could identify up to where the vertical fracture is. Therefore, determining or assessing the restorability of the case and ergo plan better with better prognosis to our patient, less repeat procedures in the context of maximizing the ability or our ability to see what is inside. Again, CT scan will not diagnose it, it is us, the doctors, that will interpret and diagnose and eventually plan, but three-dimensional image will greatly help in our diagnosing and therefore planning. Okay, so that is increasing view. So again, another particular case impacted, actually, we did not see that impacted tooth before. My friend who does the ortho, later on, we later on found it while we were actually doing it. And again, CT scan will be able to show us something that is very much hidden away from us. Implantology, of course, that's where most of CBCT is directed. We could actually determine how much bone there is, and not just that, we could even determine um, plan ahead of time where we could place the implants. And in this case, we could tell our patients what our plan could be, how would we be predictable. Like in this case, I've told the patient we cannot place an implant because obviously there's no bone, not unless you want tooth coming out of your palatal vault. That's where the bone is. I could place implants here. He patient agreed that if they would like implants, then bone grafting has to be done, and that's where planning comes. So we know that there's not enough amount of bone. We know how much bone we need, and that's what I did. I created more bone based on what we wanted to have, based on the implant sites or plan that we had before. And eventually, we ended up what we wanted. Implant placed on the site and location where we would like to have implants coming out. So predictability was became possible because of three-dimensional imaging. Okay? And now it has blown to larger extents in terms of implant planning. Because of three-dimensional imaging, CBCTs, we could now use softwares to actually plan ahead of time implants. And even with the advent of um, printing, three-dimensional printing, rapid prototyping, we could now move and create a digitally guided stent that will transfer our plan from our computers to our patient. So this is where technology is advancing to a point wherein it makes everything a little bit more predictable, a little bit. But again, um, this still requires skill of your doctors. So a lot of these papers will be coming out wherein the precision of um, computer guided, CT guided placements is leaves very little room for errors. Done properly, planned properly. Mm. And we go to this particular summary given by James Hopp, one of your maxillofacial surgery editors, authors. He is the editor of Journal of Oral Maxillofacial Surgery. And in one of the editorial that he made, he looked into cone beam CT scans and incidental findings. In his editorial, he looked at a lot of different incidental findings, and he eventually said that most incidental findings have very limited or no serious implication to our patients. However, as we increase the use of this technology, cone beam CT scan, we must take care to view the entire image itself and not just concentrate or focus on what are we doing. Implant sites, impacted molars, incidental findings are there. That's why if we look at learnings or learning CT scans, it has also moved a lot further than before. Papers such as this exemplifies why we need to study CT scans or CBCTs, particularly in our profession, because CT scans by itself is able to detect very clear defects. Like in this particular study, defects in bone. But what the study also showed is that the defect was highly detected and observed mostly by oral maxillofacial radiologists, people who study radiographs, images, sorry, digital diagnostic imaging versus the clinicians, oral maxillofacial surgeons that place the implants. Okay? Now, a lot of these papers have been shown time and time uh, that says that technology is there, but we need to actually study it in order to maximize the technology. We do not have as much automaxillofacial radiologists, and that's why even in the United States, training of automaxillofacial surgeons actively involves as well CBCT interpretations, part of the continuing education, training, and image interpretation, because part of our responsibility increases as we use newer technologies that were invented in order to make things more predictable and a little bit more accurate. But like what I've said, the technology itself will not diagnose it for us. It is up to us to properly interpret the better images that we get. So it still boils down to the ability of the doctor to properly interpret the new technology that was there. The technology is there, it is accurate, it is very precise in certain situations. But if the doctor that owns it doesn't know how to interpret it, it would be rendered useless. Okay? Having said that, CBCT still has a lot of limitations. Like what I've said, we cannot get it all, and we still have to account for that. That's why most CBCTs are continually being updated, upgraded in terms of how it could increase not just the reliability, but also the predictability of the images that we do see that may help us diagnose and therefore create a better treatment approach or plan for our patients. Okay? Again, remember, in terms of interpretation, our basic knowledge of anatomy is important since we are looking at identifying what is abnormal. We have to likewise know what's supposed to be normal. High-level principles still exist even in three-dimensional imaging. So, as recommended, if a plain film periapical radiograph would suffice, moving to more to a higher uh, exposure might not be as sound in terms of judgment. One good thing about CBCT, since we have that interface, we try to play around with it. We have to learn, relearn its uses. It takes time for you to learn how to appreciate each individual slices. It doesn't come immediately or readily. Thankfully, since CBCTs are in programs that we could view, we could actually go over it even when we go home and we are not limited to our workplace. Okay. So in finality, for this particular demonstration lecture, I go to what my old professor told me in school: what the mind does not know, the eyes cannot see. So definitely in terms of interpreting images, especially three-dimensional images, if you do not know what you are looking at, even with a good set of eyes, you cannot see what others may be seeing. So thank you very much for um, attending this online lecture and hope this will enhance your understanding of what three-dimensional images are, in particular what cone beam CT scans are, its difference from medical CT scans, and its increasing applications in the field of dental medicine.